Hello everyone, welcome to Ayucult. We are back with another video. Today we are going to discuss about gout. Gout is a type of crystal arthropathy. Crystal means crystal formation in the synovial fluid and arthropathy means pathology of joint. There are many other crystal arthropathies which we will discuss under the point of differential diagnosis in this session. Let's go through the points which we are going to discuss in this session. These are introduction, etiology, signs and symptoms, pathophysiology, types if present, investigations, laboratory and radiological, differential diagnosis, management, medicinal and surgical, and some other information about the disease, that is research or new guidelines about its management. This is going to be our format for the upcoming videos as well. Let's start with the introduction or definition of gout. Gout is an inflammatory arthritis usually affecting small joints, that is the first MTP joint, metatarsophalangeal joint, arising due to deposition of monosodium urate crystals in and around synovial joints. Gout is predominantly seen in males. So remember, whenever you have a male patient with sudden joint pain, think of gout. And whenever you have a female patient with sudden joint pain, think of rheumatoid arthritis. This is true often, but not always. Gout is derived from a Latin word gutta, which means drop, because earlier this disease was thought to be caused by dropping of diseased matter from blood into the joints. So gutta became gout. Gout is also known as the king of disease because it is one of the oldest diseases known to man. It is also called as disease of king because in those days wealthy people were affected. So remember, G in gout stands for great toe, that is the first MTP joint, and U in gout stands for uric acid because gout and hyperuricemia are often associated with each other. Now let's look at the etiological factors, that is the causes of gout. These can be classified into three categories. First, factors that affect renal secretion of uric acid. These are excessive alcohol intake, usually beer, renal failure, lead toxicity, and even lactic acidosis. Second, factors that are responsible for increased intake of uric acid. These are non-veg food, that is organ meat, red meat, and any kind of seafood. High fructose corn syrup, HFCs, which is usually found in candies, breakfast cereals, and packaged desserts like muffins, yogurts, etc. Excessive intake of sweet fruit juice, processed snacks with excess sugar, for example, cold drinks. Third category is the factors responsible for increased production of uric acid. These are psoriasis, metabolic syndrome, glycogen storage diseases, for example, GC-Speedy disease, Pompe's disease, and others. The list is given in the description box below. And of course, genetic predisposition. Usually the SLC2A9 and ABCG2, these two genes are involved. Now, let's study the drugs that can increase the chances of gout. First, thiazide diuretics, that is chlorothiazide, chlorthalidone, and hydrochlorothiazide. They increase the direct urate reabsorption in the PCT. Second, loop diuretics, that is furosemide, torsemide, and bumetanide. They increase serum uric acid levels in the same way as thiazide diuretics. Third, low-dose aspirin. This also reduces uric acid excretion. Fourth, pyrazinamide. This drug used in AKT is responsible for acute gout attacks, acute nephropathy, and urolithiasis. Fifth, ACE inhibitors. Usually, all antihypertensive drugs except losartan and CCBs may elevate uric acid levels. Sixth, chemotherapy drugs implemented in cancer treatment, example paclitaxel and gemcitabine, are associated with hyperuricemia. And last, cyclosporin therapy for immunosuppression after organ transplant has an independent effect on increased serum uric acid levels. Now, let's study about the pathophysiology of gout. For this, we need to understand the metabolism of uric acid. If you understand this, it is easier to further understand the mechanism of action of anti-gout agents. So let's dive into it. There are compounds called as purines and pyrimidines, which are basically nitrogenous bases in the DNA and RNA. Among these two, let's look at purines. Now, purines can be acquired through the diet, like meat, seafood, etc., and also from the nucleotide turnover in our body. These exogenous and endogenous purines are converted into inosine. Inosine is further converted into hypoxanthine, which is eventually converted into xanthine. Now, an enzyme called as xanthine oxidase acts on xanthine and converts it into urate. This urate is converted into allantoin by the action of enzyme uricase. 80% of this urate is excreted through urinary system and 20% through gastrointestinal system. The normal value of serum uric acid is 3.5 to 7.2 mg per dl. When this value rises above 7.2 mg per dl, it is called as hyperuricemia. This may or may not be associated with hyperuricosuria, that is increased uric acid in urine. Hyperuricemia causes urate crystal deposition in joints, which is called as gout, and also has effect on cardiovascular system causing oxidative stress, whereas hyperuricosuria acts on KUB system causing urolithiasis. Now, let's study about the clinical features of gout. The constitutional feature of gout is joint pain. This pain is of rapid onset. It is worse in the morning. There is marked synovitis, tenderness, and erythema over the joint. And having said that, right great toe is the first part to get affected. Second pathognomonic feature of chronic gout is tophi formation. Tophus is an irregular, firm nodule. It can ulcerate and secrete whitish discharge. It can get infected, and tophi are usually seen in long-standing gout. Singular tophus, multiple tophi. Systemic symptoms of gout are fever, chills, and malaise. Let's study the types of gout. On the basis of duration, they are classified as follows: acute and chronic. Acute gout is characterized by acute attack of sudden severe joint pain. It can be monoarticular or polyarticular, that is affecting single joint or multiple joints. Often, several attacks take place at an interval of few days. Hence, they are called as cluster attacks. And the most important point, acute attack is not because of high serum uric acid. It is because of sudden fluctuation in serum uric acid. Now, moving towards chronic gout. It is characterized by long-standing joint pain, joint deformity, tophi formation, functional impairment of the joint damage, along with systemic manifestations like urolithiasis and interstitial nephritis. Let us study the laboratory investigations first. The gold standard investigation of gout is the presence of MSU, monosodium urate crystals, in joint aspirate or tophus or bursa. Serum uric acid level greater than 7.2 mg per dl. This is seen often but not always. Check the RFT, LFT and glucose panel to assess metabolic syndrome. ESR and CRP are elevated since they are inflammatory markers, and CBC shows neutrophilia. Now, radiological investigations. If tophi are absent, X-ray is normal. But in the presence of tophi, that is chronic gout, punched out erosions are seen at the first MTP joint. Look at the picture. USG and DECT confirm the presence of MSU crystals. MRI is not that effective in the diagnosis of gout. Look at this picture. This is a DECT, dual energy computed tomography. In a DECT scan, green color indicates MSU crystals and purple indicates calcium. You can see how both the great toes are affected in this patient. Now, let's talk about the differential diagnosis. The first one is pseudo gout or CPPD, that is calcium pyrophosphate disease. DD can be done by polarized microscopy of the joint aspirate. Needle-shaped crystals are seen in gout, whereas rhomboid-shaped crystals are seen in pseudo gout. Second DD of acute gout is cellulitis, then septic arthritis, reactive arthritis, rheumatoid arthritis, and psoriatic arthritis. In gout, the nodules are white, whereas in rheumatoid arthritis, they are reddish. And of course, anti-CCP antibodies will be positive in RA. Now, we are discussing the most important point. How will you treat a patient of gout? The management of gout is predominantly medicinal. In acute gout, you should give symptomatic treatment. And for chronic gout, you should give uricostatic and uricosuric drugs. Uricostatic means drugs which stabilize the amount of serum uric acid, whereas uricosuric means drugs which excrete the excess uric acid through urine. Symptomatic treatment includes colchicine, NSAIDs mainly indomethacin, naproxen, and glucocorticoids. Uricostatic drugs are allopurinol and febuxostat. They belong to a class of drugs called as xanthine oxidase inhibitors. Uricosuric drugs are probenecid, sulfenpyrazone, and benzbromarone. Uricase analogues like pegloticase are some of the newer drugs. Let's look at the treatment of acute gout. First drug is colchicine, obtained from a plant Colchicum autumnale. It prevents WBC migration in the joint. Dose is 0.5 to 1 mg BD. Can be used in acute attack as well as prophylaxis. Then NSAIDs like naproxen and indomethacin. They reduce inflammation and pain. Naproxen is started by a loading dose of 750 mg followed by 250 mg TDS. Indomethacin is given the dose of 50 mg QID. Then oral steroids. These are given when patient is not tolerating or responding to NSAIDs and colchicine. Dose is 40 to 60 mg per day for 5 days followed by tapering of dose. We are pretty familiar with Omnacortil and Visolon. Last, intra-articular steroids. Injection triamcinolone, that is Canacort, is given inside the joint. Dose is 10 mg for small joints and 30 mg for larger joints like wrist. Indications are same as oral steroids. Now, let's study the management of chronic gout. First drug is allopurinol. It is a xanthine oxidase inhibitor. If you remember the uric acid metabolism, we said that xanthine oxidase converts hypoxanthine to xanthine and xanthine to urate. So drugs that inhibit this enzyme can block the production of uric acid. This is the mechanism of action of allopurinol. It is used in tophi, nephropathy and urolithiasis. The dose is 100 mg per day. It can also be used in secondary hyperuricemia, which is seen in cancer chemotherapy. Second drug is probenecid. It is a uricosuric drug. It can be used in secondary hyperuricemia. Dose is 500 mg per day. It can also be used to prolong penicillin and cephalosporin levels in the treatment of subacute vital endocarditis and gonorrhea. Third drug is febuxostat. It is a pretty popular drug for gout nowadays. It is a xanthine oxidase inhibitor. Dose is 40 mg OD, which can be increased up to a maximum of 120 mg per day. But remember, this drug is hepatotoxic, so monitor LFTs of your patient. It can be used in cases resistant to allopurinol and probenecid. Last drug is sulfaneparazone. It is also uricosuric. Dose is 200 mg per day. Maximum dose is 600 mg per day. Remember, this drug can cause renal stones, so advise your patient to take plenty of water. This drug is contraindicated in peptic ulcer. Pegloticase is a newer drug in gout treatment. It is a uricase analog. It is indicated in resistant cases of gout as well as chemotherapy-induced tumor lysis syndrome. It is given as an intra-articular injection. Let's end this session by talking about the research that has taken place for the treatment of gout. The role of obesity, physical inactivity, and abnormal sleep patterns has been proved in the etiology of gout. New drug called as lesinurad, which is an oral selective uric acid reabsorption inhibitor, has been the limelight. And Ilaris, that is canakinumab, is the first biological therapy accepted for the treatment of gout and has been approved by the FDA. Thank you for watching. If this video was of any help to you, do like, share and subscribe to our channel. Let's meet in the next video. For now, bye.